All right, everyone, so welcome. We're going to get started. Welcome to our third session of our series, which is our experts, medical aspects of child abuse. And we have Angie Boy and Dr. Messner here who have been so instrumental in helping coordinate this core series. And so I'm excited for the talk today. So I'm going to shoot it over to Angie to introduce everyone and the talk here.
Hey, good afternoon, everybody. Thank you for joining us for round 3. Our speaker today is Dr. Steve Messner. He's the medical director for the Stephanie V. Blank Center for Safe and Healthy Children at Children's Healthcare of Atlanta. He is a child abuse pediatrician and has been at Children's now for 15 years.
Yeah.
Some of you on the call today have probably had him in your courtroom testifying. So he is going to be speaking on the medical patterns of child abuse. He's going to talk fast. He promises us he's going to talk fast because he does have a lot of material to cover. If you have questions, feel free to use the chat pane or the Q&A pane, and we can address them to Dr. Messner. He'll also have his contact information at the end. And then when we finish, we will provide you with an evaluation survey for today's session. So with that, I'm going to turn it over to Steve.
Great. Thanks, guys. And let's just double check that didn't work. So let me share the other application. There we go. I think. All right. So we're going to talk about medical patterns of child abuse, and not just limited to physical abuse. I'm going to touch on a lot of different things, but I just wanted to start off with a little bit about us as physicians, and just to remember that we're not all trained equally. And I think this is really important when you're talking with like defects workers or law enforcement. If they've gotten information from someone at the hospital, it may not be someone who has as much experience or knowledge in child abuse as those of us who are child abuse pediatricians. So for us to become physicians, we all do 4 years of undergrad, and that can be in whatever you want it to be. But getting your basic sciences in, and then it's 4 years of medical school. Here in the US, you either graduate, if you went to a osteopathic school, then you graduate with a DO, otherwise you graduate with an MD, and then you're considered a physician, but really you wouldn't want that person treating you or any of your loved ones. You really need to do the residency afterwards. So if you've completed all of your schooling, then you do something called the match, and it's for residency, and that's either a minimum of 3 years, which is all of your primary care tracks, which would be like pediatrics, internal medicine, family practice, up to 7 years, which is the longest one, and that's like neurosurgery. And there's varying lengths in between there. And then you can do additional training after that, which is something called a fellowship. So child abuse pediatrics is one of the most recent pediatric subspecialties. There's now hospitalist medicine is boarded after child abuse peds. We became a subspecialty back in 2009. And in order for a doc to sit for the boards, they have to complete the residency, and the ACGME is just kind of our governing body of graduate medical education, and then do a 3-year fellowship. So there's 29 accredited programs in the US. We are one of them. We've graduated 4 fellows. The other, nearby fellowships are at UF and up at Duke. And our areas of expertise, and we call ourselves CAPS, like child abuse pediatricians, are in child physical abuse, sexual abuse, neglect, all aspects of neglect, medical child abuse, which is the term that we prefer to use for Munchausen syndrome by proxy. It's a lot easier to say, but it also puts the emphasis back on abuse, and that the caregiver is manipulating the medical system to abuse the child, and then psychological and emotional abuse. There are 346 board certified CAPS in the US, and 5 of them are here at Georgia, 3 at Children's Healthcare of Atlanta. When you look at the population here in Georgia, about 2.5 million children with a victimization rate of 3.5 per 1,000. That puts the ratio of child to child abuse pediatrician is like just over 500,000 children per child abuse pediatrician, which isn't the greatest. When you look at victims, it's about 1,700 victims per child abuse pediatrician in Georgia. This is kind of the heat map distribution. There are some states that do not have any child abuse pediatricians. A lot of states will utilize physician extenders, which is what we do here at Children's Healthcare of Atlanta, where we use advanced practice providers. So we use nurse practitioners. Some other places will use physician's assistants. Sometimes there's pediatricians or family practice docs out in the community who are not board eligible, but have been doing this type of work for a significant amount of time and do have expertise. So you kind of want to vet your expert. So if you know that they're board certified in child abuse pediatrics, then that's an easy one. But if they're not, then you really want to go through that process and kind of understand how they're able to speak with some authority about the mechanisms of injuries or the types of infections that the patients have and how they relate that back to whether or not it's abuse or some other medical condition. Our center here is the Stephanie V. Blank Center for Safe and Healthy Children. We have 2 different locations. We're one of the child advocacy centers here in the state of Georgia. We're one of the few medical model child advocacy centers. So we see children at our center primarily for historic cases of sexual abuse. They'll get their forensic interview, but we're also able to do a medical exam on either campus, either by Scottish Rite or at Hughes Spalding. And we'll also see children for follow-up. So if we saw them acutely in the hospital, primarily for physical abuse concerns, we'll see them back about 2 weeks later. And the same thing if we saw them acutely in the emergency room for sexual assault concerns, we'll see them back in about 2 weeks. This is probably not news to anybody on the call, but put this in here just to remind folks about child maltreatment and the victimization rates, that it does exist, and that the youngest victims are the most victimized. So if you look at this, is from the NCANS data, the less than 1 year of age is the biggest bar. And the same thing goes with fatalities. They're the most frequently victimized age group. So it's really, these very young ones are the most vulnerable. And that's why we are so emphatic about getting workups on these kids and making sure that we've uncovered every leaf, looked under every rock when we're concerned about abuse in this very vulnerable population. The same can be said about the elderly and the special needs populations. Just anyone who's really dependent on somebody else for their activities of daily living are at risk for victimization. Where we intersect with this most is in the young population, but then also with the special needs. A little levity here. This dad did not really do this with his kids. He's a master at Photoshop. There's actually some really good Instagram things out there with people positioning their children in kind of precarious situations. But I wanted to start off with fractures and looking at what types of fractures are associated with abuse. Are there specific types of fractures that are only associated with abuse, and how we can distinguish abusive fractures from non-abusive fractures. Like anything, we really need to take this in the context of the history that's provided. So what kind of force or accident happened to the baby, and whether or not that baby is developmentally able of generating those kinds of forces on their own body. To create a fracture, you really just need to apply a force to the bone beyond the ability of the bone to resist that force, and then it fails. So these are the different ways that you can put the forces on the bones. You can either squish it down, that's a compression force. You can pull on it, that's tension. You can bend it, you can twist it, that's a torsion force, or you can put some shearing forces on it. And in real life, it's not a lab, so oftentimes it's not just one of these forces being applied to the bone, whether it be an accidental mechanism or a non-accidental mechanism. Okay. Oftentimes we'll have a combination of these forces. And when these forces are applied to a long bone, this is just an example of the femur, which is the thigh bone, where you see at the left top is a normal femur. And if you had a pure bending force, then you would have a transverse fracture if you put enough force on the bone to cause it to fail. If there's a little bit of a twist to it, then you wind up with an oblique fracture. If it goes around, then that's a pure torsion force spiral. If it's blown to bits, that's a comminuted fracture. That indicates that there's much more force present on the bone to cause it to fail, because it didn't just fail in one fracture plane. It kind of split the bone. Same thing if it's if the bone is broken into a couple of pieces, that's what we call segmental. If it's pulled off in a avulsed fracture, if it's impacted, that's indicative of a compressive force. Now, these last two are only seen in pediatric bones. So a torus fracture is often called a buckle fracture. It just means that the bone is kind of buckled. The last one is a green stick fracture. And I'll show you guys examples of what these look like. But you only get these last two in pediatric bones because they're much bendier than adult bones, because they have a higher percentage of cartilage in them. So it's more like your ear than our femurs. Our bones would not break this way. There's a pediatric radiologist who looked into, the question of, can we look at different types of fractures in children less than 1 year of age? So these are kids who are not very mobile, and kind of look at the fracture type and see if there's any kind of specificity that we can put just on the fracture type alone, with if there's no history of any kind of trauma, as to whether or not it's highly specific for abuse, moderately specific for abuse, or it's a common fracture and has a low specificity for abuse. And he was able to do that. And this is some an older study, and he actually looks at all of the different bones. He has lots of papers out, Dr. Kleinman, that looks at these different bones and fractures and about the healing that occurs in those fractures. But I'm going to go over what the high specificity fractures are, and I'll show you what they look like. So these are the classic metaphyseal lesion. This is sometimes known as a bucket handle fracture or a corner fracture. Very high predictive value for being abuse in children less than 1 year of age. This is from his studies. This is the fracture type that we see most frequently in fatal abuse. And it's not because it's a high energy force that's required to make this fracture. It's that fatalities are generally from head trauma. And we see this fracture being caused by a result of tension or shear loading forces. So at the ends of the bone, it's at the weak point of the bone, it's at the growth plate. And so in an abusive head trauma situation, if a child is picked up and they're grasped about the chest and they're shaken or they're slammed down into something, their arms and legs are generally not held steady with the body. So they flail about. And where you get the fracture or the force kind of concentrated is at the joints. So at the shoulder, at the wrist, at the elbow, at the hip, the knee, and the ankle. And so when the arms and legs are kind of whipping back and forth, if there's a significant force there, it'll actually cause the soft tissue to, which is stronger than the bone, to pull that part of the bone off. And so that's how you get this corner fracture. And we just call it a corner fracture because it looks like the corner is pulled off. So you see here, the white is the bone, and this is a young infant. You can tell that just by looking at this. You see the growth plate is still open. You don't see the kneecap, which would be right here. Does that show up? I don't think it does. But right in the middle, see how there's like this space between the bones. You have the femur at the top, which is your thigh bone. Then you have that little round dot, which is still part of the femur. And then below that, you would have your kneecap or patella. You just can't see it because it's not ossified yet. It's all cartilage. And then at the bottom of the image, you see the tibia, which is your shin bone. And then that smaller bone on the left of the image is the fibula. Where that black arrow is, you see that the corner of the femur, it's kind of pulled off. It's a corner fracture. That black or gray line going through the corner of the bone is where the fracture is. Here's another example at the wrist. So this is the radius and ulna, and you can see how the white bone, the ends of it are pulled off. The corners are pulled off. This is what it looks like if you're just looking at it from a different view. So X-rays take a 3D object, so our body or the bone, and they compress it down into two views, 2 dimensions. So you're just looking at it like a photograph. If the X-ray beams go through that fracture line, it'll look like this. And it's the exact same fracture, but we call this one a bucket handle fracture because it looks like the handle of a bucket that's kind of raised up. So the radiologists just kind of like to be descriptive about what these fractures look like. These are the exact same fracture. It just is the way that the X-ray beam is catching the fracture plane. The next high specificity fracture in young infants are rib fractures. They're very rare to be caused accidentally in children in general. If we see a rib fracture without any good history of trauma up until age 3, there's good studies that show that we should be looking for other signs of abuse in those children. It's actually very rare, less than 1% of accidental fractures. When we see just an isolated rib fracture, it's typically there's no history of trauma and that it's picked up what we call incidentally on as chest x-ray. So if a child comes in, there's a concern that they swallowed a quarter, or there's a cough, or there's vomiting, and they wind up getting a chest x-ray and find rib fracture, then we really need to start looking for other signs of abuse in that child. Usually the caregivers don't notice this on exam. Sometimes they'll tell you that it felt a little bit of like a pop or what we call crepitus. These are when we tell parents that, hey, there's a rib fracture there or multiple rib fractures, then we start going down this pathway of, well, what else could this be from? We know that birth is traumatic, but it's very rare to see this from birth trauma. One study that showed no rib fractures. I personally had a couple of cases where we did have some rib fractures, but when you spoke with the provider who was there for the birth, they tell you that it was very dramatic and they were rushing to deliver the baby, and so there was that squeezing force about the chest. From CPR, it's also very rare, and usually this is from a trained professional, and they'll tell you that they can feel when the rib actually fractures. And when that happens, it's on the front or the anterior part of the body. This is what I was referring to earlier about children who are less than 3 years of age. If they have a rib fracture and there's no history of any kind of trauma, that is a really high predictive value for being abuse, 95%. I mean, that's really, more than a reasonable degree of medical certainty. Usually when we see these, they're on the back of the body, which is what we call posterior, or they're lateral, so they're on the sides. And the number of rib fractures that you have, the higher number, the more likely that it's going to be a fatality. This is because of kind of the forces that are going on during that act of violence on the child. A question we get often asked about is bruising nearby. It's very rare to see bruising, and that's because the force that's applied to the chest is usually not a sudden impact, which is what causes bruising when you get that rapid change in the pressure in the blood vessels, causing the blood to leak out of the blood vessels, which is what a bruise is. It's usually more of a forceful squeeze where it allows for the soft tissues to kind of conform to the hands, but then you get that pressure on the ribs until they fail and then they break. So you're not getting that initial blunt force trauma. This is a schematic of a chest at rest. You can see that this is the typical position that a adult is picking up a caregiver. At the bottom of this photo, this sketch, you can see that where that black arrow is, that is pointing to a posterior rib fracture. So that is the vertebral body in the center. Then you see the ribs coming out. And then at the top of the photograph or image is the sternum or the breastbone. If you think about when people pick up children, they typically will pick them up facing one another. So that puts their fingertips towards the back of the body, which is what you see in this diagram, and then their thumbs on the front of the body. And if they squeeze, and what this is trying to show is the kind of grayed out area is the chest at rest, and then the elongated image is the chest compressed. And where the ribs will predictably fail is posteriorly, where those fingertips are, and then laterally, where they bend, and then snap. Sometimes we'll see them anteriorly, but it's much more common to see them posteriorly and laterally. This is what it looks like on a chest x-ray. Same this is the same orientation where any kind of cross-sectional imaging that we do, the convention is to have the patient lay down on the table on their back and the feet are towards you. So what you're looking at here is at the bottom, that kind of triangle where the big circle is in the middle, the black, the white around it, that is the vertebral body. Then you see the ribs coming out on both sides. The little spaces between the ribs, that's normal. That's just you're seeing between the subsequent ribs. What's abnormal is where that black arrow is. That's a very fresh or acute posterior rib fracture. And then on the right side, which is the patient's left, you see another black arrow. There's this big lump of white. That is what we call a callus. So that is a healing rib fracture, and that's on the lateral side. So it's on the side of the body. So in this one image, you can see that this individual has had two instances of trauma to the chest, compressive trauma that caused a more recent rib fracture and then a healing rib fracture. If we happen to get a CT scan, which we don't often get on the chest, we will do something like this. So this is a CT scan. You see on the right side, that kind of lump, that's a healing rib fracture. And what we did was did a 3D reconstruction on this. And so now you can kind of see, this is with the patient upright. You can see how the ribs don't come all the way together in the front. That's because you have the cartilage there, the cartilaginous ends of the ribs. But when you look over here on the left side of the body, you can see those big lumps on the ribs. Those are healing lateral rib fractures. And it's more common to see them in subsequent ribs. So that's, you know, rib 3, 4, 5, 6, 7, like in this case, just because that's where, you know, the pressure is kind of being applied over the body. Here you can also see at the back, you can see a healing on the right, these posterior rib fractures, and then also one on the left. You can still see the fracture line and then that callus that's formed about them. After rib fractures, we'll quickly go over these last two that are high specificity. So scapular fractures, so that's your wing bone. It's very rare to see these in pediatric patients. Usually we see them in adolescents. It's usually from, you know, adolescent boys doing parkour who like jumped off of something, or they were at a motor vehicle crash, or they fell from a significant height. Usually what breaks off is this acromion, which is kind of like a little beak that goes over the upper arm bone, which is the humerus. And the way that you get these from an abuse scenario is either a direct blow, so someone strikes the child on the shoulder, or they grab their arm and they yank it up very forcefully, and it causes the humerus to kind of snap that acromion off. And this is what it looks like. I wish you could see my little arrow. Maybe if I did this, laser pointer. Right here is the fracture, okay? And then here, this is where there was direct trauma to the scapula, and there's, see how it's bent? It shouldn't have that bend in it. So there was trauma right there to the body of the scapula. And here's another acromion fracture of the scapula. The other one is the sternal fractures, which are, again, unusual in children. Same thing with like pelvic fractures. This is from direct blunt force trauma right to the anterior chest. When we see these and pelvic fractures, we should think about the child being stomped or punched. If it's not in an abuse scenario, it's from a motor vehicle crash or a fall. And you wind up getting kind of this fracture right to the body of the sternum. I just want to briefly talk about these other fracture types. These are not specific for abuse, like those top four were. We talked about those high specificity fractures for abuse in a child less than 1 year of age, but these are the fractures that we only see in pediatric bones. And so this buckle or torus fracture, it's kind of like the buckling of a road. It's not like your belt buckle. And this is what it looks like. So the bone here should not have this lump here or here. And you look at it from the side and see how this is the same forearm being imaged straight on and then from the side. So we call that like an AP and lateral. And you can see how it kind of lumps out. This is a very common accidental fracture that we see in children who fall and put their hand out, and we call that a foosh, fall on outstretched hand. And then you get the force being directed up from when you land on the palm of your hand, up the forearm, and causes the bone to just kind of crunch, almost like you're stepping on a soda can. Sometimes it'll have a little, break in the bone right here. This is a buccal fracture down by the ankle. Same thing here. Again, not specific for abuse, but we'll only see these in pediatric patients. And our bones will break like this, like a twig. If you snap a twig, it's going to break into two pieces. Versus pediatric bones can sometimes break like this. We call it a green stick fracture because it's just like trying to break a fresh green stick or a switch. It's a bending force on the bone, just like we saw with like a transverse fracture. But what you wind up happening is that the bone will not break all the way through. So you wind up just kind of splintering the bone. And these are all in the forearm. And they come in kind of different varieties. Now, a transverse fracture is a pure bending force. It causes the bone to break straight across like this on the femur. Oblique is kind of a combination of those bending and torsion forces where you wind up getting this angled break to the bone. And then if it's a pure spiral force on the bone, then you wind up getting a spiral fracture. And as you can see here, kind of looks like a helix, spiral staircase. To cause a bone to break in a spiral fashion, it takes 1/10 the force as it does to cause it to break in a transverse fashion. It's because you're not going against the strength of the bone, because the way that the bone, the strength runs from top to bottom in the long bones. And so if you have a pure bending force, they're acting as a unit, almost like cables on a suspension bridge. But if you twist them, then you can wind up breaking them individually. And so that's why you wind up being able to fracture a bone much more easily in a spiral fashion. And this is a pretty common fracture that we see with kids who are running around and plant and twist or get struck by another child and break their femur in this fashion. The old school thinking was that if you saw a spiral fracture of the femur in a young child, then that was pathognomonic of abuse, which is not the case. So we'll sometimes get kids transferred in from outside emergency rooms, and the concern is about abuse because there's a spiral fracture, but it's a 3-year-old, 5-year-old kid who's been up and running around, and it's a very reasonable scenario for them to sustain this kind of fracture. In skull fractures, we see these all the time. These are down in this is in that common low specificity bucket of pediatric fractures. Not all skull fractures are the same. They come in different flavors, if you will. So linear, if they're complex, depressed, and ping pong. Linear is the most common, and we can see this from a short fall, and we do see this from a short fall. So someone puts a baby on the bed, and they wiggle off or they roll off and they fall onto a thinly carpeted floor or a hardwood floor. They put them on a low elevated surface like a countertop, and they fall off. They're most commonly going to strike with their heads because kids' heads are disproportionately heavy than adults, and so they usually lead with their heads, strike the side of their head, and then break the parietal bone, which is on the side. And so very, very common to see these. If we don't see anything else on the workup, then we know that it fits that scenario. Sometimes people are reluctant to say, though, that they dropped the baby. And so then we need to do that workup and make sure that we're looking into other more specific high specificity fractures for abuse. Now, this is a different scenario where this skull is broken in multiple places. You see all these arrows. Again, the dark is the fracture lines, and this is very different amount of force than one that you would see from a short fall. And we consider a short fall up to 4 to 5 feet. This is much more force. This would be more like falling multiple stories or being struck in the head by something or being slammed down into something that's unforgiving. Sometimes the bone is not just fractured, but there's enough force to also push the bone towards the brain. And that's what we call a depressed skull fracture. Again, more force being present to cause that. In little babies, we'll sometimes see these ping pong fractures where the bone is just kind of like dented in. It's like a green stick fracture of the skull. Doesn't necessarily mean that there was more force applied. It's just a variation on a parietal skull fracture. We will, here at Children's and most institutions now, will get a CT scan of the head to look at the skull fractures, and then also to look at the contents of the skull, so looking at the brain and seeing if there's any bleeding there. This is the same patient, and what we did was a 3D reconstruction of the skull. This is a normal, what we call suture line here, and suture line here. This here is abnormal. So this is a linear parietal skull fracture. Not super concerning in and of itself, even without a history of trauma. What we would want to work that patient up. This is what a ping pong fracture looks like on CT scan. You see how it's dented in. This shows where the infant skull is not one fused helmet yet. All the bones are still separated by the sutures. And here's what we call the anterior fontanelle. That's that soft spot that grandma tells everybody not to touch. And this is what, when we image infants, you wind up picking up anything that is, is more dense. So like this is a little baby with a binky. No fractures. These are all normal sutures. Fractures do heal over time. We start to see callus on the x-rays in about 1 to 2 weeks. This will help us to age them, except for the flat bones like the skull. And this is an internal cast, which stabilizes the bone. You can see over time, you start having this bleeding initially, then you get the callus, then you get a bony callus. This is when we start seeing it on x-ray, so at about 10 to 14 days. But then over time, the bone's going to completely remodel. Our bodies have a remarkable ability to get the bones back to looking how they should before the force was applied to them. So there's really no value in getting x-rays on an individual if you're looking for fractures from 6 months or further in the past. You just won't pick that up on the x-rays. What we do is something called a skeletal survey, which is a lot of images of the bones. And the reason we do this is because when you take the x-ray, you need to make sure that that bone is in focus when you get the x-ray. You don't want to just take an x-ray of the whole body. And the reason we do that is we want to make sure that we're not missing out on these highly specific fractures, particularly those corner fractures, which are at the ends of the long bones, because they're so specific for being abused in young children. And then we'll repeat them in about 2 to 3 weeks. We can pick up subtle fractures that could have been missed on the initial x-rays. We give the bones time to start healing. Some places will eliminate a couple of the films to decrease the amount of radiation. Our radiology groups continue to do them. This is an example of a chest x-ray on a little baby who I saw years ago who had, this was read as normal. This is what we call the AP and then the lateral. And then we had this baby come back. And this is 14 days. And what you can see right here, there's these big white lumps right here. These 3 healing posterior rib fractures. There's actually 4. And this really changed the trajectory of this case. So that's why it's really important that these infants come back and get the repeat skeletal survey, because without seeing this, it was still more of a suspicion of abuse. This really confirmed the diagnosis that this child had been a victim of physical abuse. And switch gears from the inside of the body to the outside of the body. Physical abuse, there's no group that's immune to this. It can happen in all age ranges. The way the American Academy of Pediatrics recommends kind of helping to distinguish between whether this is punishment versus abuse is if the cutaneous injuries last greater than 24 hours. And that was kind of decided at a meeting with a consensus among the experts to help distinguish between, whether this was some type of punishment that was causing a temporary reddening of the skin versus causing bruising, because the bruising would last more than 24 hours. Now, here in the state of Georgia, corporal punishment is allowed. You can definitely have abuse that does not cause any external signs of injury. So we just use this as a, kind of as a guideline about whether we see some temporary reddening of the skin. And if it goes away, we'll look at that more as a punishment. There's a great rule, this bruising clinical decision rule, that I'm going to go over with in some detail with you guys. Just want you to understand how this came about. So they did a 3-year study looking at children from 0 to 4 years of age, so 48 months. These were all kids who went to the intensive care unit, and they looked at about 70 patients, and they split them up. 33 were known to be non-accidental trauma, and 38 were known to have accidental trauma. And that was independent of the study. This is how they grouped them after they enrolled them in the study. And what they found was that there was a statistically significant difference in the bruising locations and the numbers between the abuse group, the NAT, non-accidental trauma group, and the accident group. In the accident group, it was a small number of bruises, so up to 4, less than or equal to 4 bruises total, but median of only 1.5, versus the non-accidental trauma group up to 25 bruises, and the median was 6, so 4 times that of the accident group. In the non-accidental trauma group, they saw that there were bruises that were only seen in that group versus the accident group, and that was bruises on the ears, the neck, the hands. They did laterality on the study, so they said the right arm, but it's really the chest, the buttocks, that they were perfectly predictive of abuse. And then the back and the abdominal regions of the torso, they approached statistical significance between the groups, and they only saw injuries in the genital and the hip region in the abuse group, but it was too small of an N. There weren't enough of them for them to say, hey, this is something that we should classify as being abusive. This is just some data, and we'll get this out to you guys, but you can kind of see how they got the torso, head, and neck, and this is the solid bars or the abuse group, and then the hashtag is in the accident group. So they came up with this, and they found out that this rule correctly identified abuse. It had 97% specificity, and it correctly identified an accident, so that's your sensitivity, 84%. So this is really good. So then what they did was they called it the 10-4 bruising clinical decision rule. So 10 meaning T for torso, E for ears, N for N, 4, and that it was validated, they came up with this rule up to 48 months, so 4 years of age. But then they said, and children should not have injuries anywhere on their body, any bruises, if they're less than 4 months of age, because they're not yet mobile and able to self-inflict injuries. So then they did another study and they validated this. So they went forward, for almost 5 years using this. They screened over 20,000 children and then were able to enroll over 2,000. They looked at 34 body areas. So they broke it down. It's very granular. And they found that it was almost 96% sensitivity and 97% specificity for these being injuries that were indicative of abuse. And it was not just the TEN regions, but also the frenulum, the angle of the jaw, the fleshy part of the cheek, the eyelid, and the subconjunctival hemorrhage. And that nicely spells out faces. So that's how they came up with this 10-4 faces. And then the P is for pattern bruises, clinical decision rule for bruising. So this is T. So injury on the torso. It can be on the front or the back. That's your T. It also includes the genitals. Typically when I see injuries on a little boy, it's potty training related. So they expect them to be potty trained at 2. And then he has an accident and then they squeeze the penis. And so you wind up with these kind of injuries. The E is for ears. So very unusual to just have injury to your ear without any other surrounding injury. When you have it on the edge of the ear, it's from the ear being pinched. see it on the back of the ear if the patient was slapped across the face, and you kind of slam that ear into the skull. Injury on the neck is a very protected area of the body, so to have that injury there, again, highly predictive that this is an inflicted injury. Oops. And then here we get into the faces part. So the frenulum. Inside the mouth, we have 3 different frenula. There's the one at the superior labial frenulum, so that's connecting the inside of your upper lip to your gums. There's the one at the bottom, the inferior labial frenulum, and then there's the lingual frenulum, which is under your tongue. When we see this in a young child who doesn't have any teeth, we have to think about either direct trauma to the mouth that's causing a force to tear that frenulum, and these will not heal up and regrow back. So you can see if there's a prior injury there because the frenulum's disrupted, or someone shoving something inside the mouth, like forcing a bottle into the mouth, or a finger or a spoon, and you can wind up with that lingual frenulum injury. Here's at the angle of the jaw. Here on the cheek, so the fleshy part of the cheek, usually from someone squeezing the child about the face. On the eyelid, and then the S for faces is subconjunctival hemorrhages. We used to think, hey, this is just something that just pops up in kids. Maybe they're coughing too much or sneezing or vomiting. They did a good study looking back 4 years at 86,000 exams, and look, they only found less than 1,000 that had subconjunctival hemorrhages. Most of them, the kids had surgery, so 600. So there's really only 313 out of 86,000 exams that had, subconjunctival hemorrhages that they couldn't figure out what was going on, that it wasn't related to the surgery. This shows that it's very rare to have subconjunctival hemorrhages. In this study, they saw that the majority of them was from trauma. There was some, inflammation, so conjunctivitis. They detected that there was a lesion on the eye. Only 3 they felt were due to coughing or choking, and 2 of them had a bleeding disorder. So you see the big bulk of those, 261 out of the 313 were from trauma. So this was the conclusion that it's very uncommon with a very low prevalence, less than 1%. It's due to trauma or inflammation, and that spontaneous ones are very rare, if occurring at all. And so we now have retrained ourselves to think of these as a bruise to the eyeball. So if we see this in a young child, we're going to go ahead and do the workup, which was kind of a change to our practice. And then the P is patterned injury. So pattern, like here's a loop mark, which could be from a belt, could be from a cord, something that's looped over, just has a pattern to it. There's another pattern where you see lines and parallel lines. So the outline of an object, either like from a paddle or from a ruler, or potentially from a belt if you're not being struck by the looped end of it. If you get struck with it dead on. Here's a pattern within a pattern, so a braided rope. Sometimes we see patterned injuries that are from, a branding, so like from a clothes iron. Sometimes they overlap. Here you see lines, parallel, kind of going in different directions, like a belt that has a raised edge to it. Try to train folks to not try and always try to figure out what the object is, but just to recognize that there's a pattern there and know that this is not what you get from normal play, bumping into things. This is a classic pattern for a slap mark where you get these lines of petechiae. Sometimes you see the tips of the fingers from being struck with an open hand. Actually, what people are using as objects to injure children are things that are nearby. They always have their hands on them. There's their belt on them. You can see that this is the belt buckle here. You can see the tine. You can see that she also has a subconjunctival hemorrhage on her eyeball. Sometimes we see bite marks. If we see these and it's recent, humans will bite and let go. Animals will tend to bite and rip the tissue off. We'll take pictures like this. This ABFO stands for the American Board of Forensic Odontology, where they can try and do bite mark analysis. It's very, very difficult and it's been challenged a lot. What we recommend is to go ahead and swab the area just like you would in a sexual assault kit. And we've had some good results of getting trace evidence off of there from the saliva. And sometimes you can't really make out the teeth all that well, just like this. Here's one where you could see the bruising from the suction. I had a odontologist put the numbers on here so you can see the numbers of teeth. In general, if the spacing, if you can make out where the eye teeth are, the canines, and it's over 4 centimeters, 3.5 centimeters, you can say it's consistent with an adult sized male. But again, it's really difficult to be accurate because of the tissue wherever you bite on the body can kind of deform. So things can look different when they're just at rest. Sometimes we'll see this patterned injury. Looks like a little U or a horseshoe. This is from a Bic lighter, very classic horseshoe shape or parabola. We just took this lighter, put some lipstick on it, and then stamped it over the next to and on top of the injury. I was able to say in court that this was, consistent with being burned with a Bic lighter. There was a fellow that didn't get published, but they did a study where they held lighters and kept checking the temperature with an infrared thermometer on the metal to see once it got hot, and it took like a long time. It was like over a minute. So this wasn't like, oh, I was lighting my cigarette in a windy day and it kept blowing out and I kept relighting it and then accidentally bumped into the child. To get a branding injury like this, there really has to be some intent behind it to cause that injury. And sometimes they're hidden. This was hidden on this little baby's neck. And here you can see the striker wheel, which is that rectangle, and then that horseshoe shape to the lighter itself. Sometimes you'll hear about this. People put in the chart, oh, this is an older bruise, this is a younger bruise. You cannot accurately age your bruise. So as much as we'd like to, you can really only do it at autopsy if you do a punch biopsy and then you see if the red blood cells are kind of gobbled up by these other cells called macrophages. So it's so impossible to accurately age a bruise. So we won't do it. I wish we could, sorry. If we see babies or children who have a lot of crush injury, we will check for injury to the muscle itself. So checking for the proteins that get released, and that's your CPK. We've had children go into kidney failure because of all of this crush from being struck with, like with a belt or with a rubber hose. It's kind of like people who go into rhabdomyolysis from running a marathon and they weren't very hydrated. Okay, I'm going to show you, these are probably the worst, the toughest pictures to look at, but I just want to show you guys what immersion burns look like. So it's not commonly we see this as, again, a potty training is the provoking incident, and they take the child and they hold them like this, put them down into the hot water, and you wind up getting a very classic pattern to the burn. So you wind up getting like this donut-shaped burn where you have injury to the tissue sparing at the buttocks and then above it. Same thing with, this is what it looks like in a little African-American baby. I think this shows it the best, where you can see where she was seated on the tub, so she's not in contact with the water at the bottom. And then all of this red is where the water line was. And you can see on the front of her body, her little knees were up out of the water where the skin on skin was. It spared that area. And you can see that her right hand was held down and her left hand was held down. And children will pull away from pain. So listen, that we know where she was in the water and that both of her hands were held down. Switching to abusive head trauma, when we see a child that we're concerned about abusive head trauma, we're going to get a CT scan initially, then we're going to get an MRI. We'll check to make sure that there isn't any kind of bleeding disorder. That's what all those factors are. And we'll get a eye exam to look in the eyes. When we looked at children who have abusive head trauma, not all of them have injuries in their eyes, but about 2/3 of them will. And they'll have too numerous to count multi-layered hemorrhages, so bleeding in the back of the eyes. But about 15% will have none. The way that you look is you have to have the ophthalmologist dilate the pupil, look into the eye, and then look into the back of the eye. So they're looking back here into the retina, and this is what the retina looks like. So it's kind of like a lasagna, and there's all these, capillary plexuses that like run throughout the back of the eye. the fluid that fills up the eyeball is kind of sticky. And so if you have significant force on the body, it causes that to pull and tug on the inner layers of the eye. And it can cause this, that's called the vitreous humor, to cause the retina to separate. And when it does, and they look through it with this indirect ophthalmoscope, what you see is this is normal to have these blood vessels here. This is the optic disc. This is abnormal, where you have all of these retinal hemorrhages. And you don't get this from like vaccines or from trivial trauma. This is significant trauma to the back of the eye. And we can sometimes pick this up on MRI where that red arrow is, but really the best way to look at these is to go ahead and get the eye exam so that we can characterize them. If it's a fatality, they will preserve the eyes and then they'll look at them under the microscope after they have fixed them, and then they'll bisect the eyes. And they'll also look in the nerve, the optic nerve sheath to see if there's any trauma there. Okay, I told you I was going to talk fast. And
You got 5 minutes.
I know. We're going to talk about sexual abuse really quickly, that the dynamics are very different than adult sexual abuse. Usually they know the perpetrator. We know that grooming is often involved. So these leads to less violent encounters and less likelihood of injuries. When we do the genital exam, it's very important, no matter when the child said that this happened, for them to get a genital exam, because they may have injuries that have healed that have, long term findings. And so we can't comment on that unless we've done the exam. We can look for normal variants, but usually it's a normal exam, and that can oftentimes be very helpful to the victim to hear that their body is normal, and it can actually help them in the healing process. So we do these exams, we spend plenty of time preparing them, making sure that they have the upper hand in this and that they are driving this ship. So if they don't want to have the exam, no problem, we'll listen to their wishes. Sometimes people ask, like, when do we need to do, why don't we just sedate them? We will on occasion. I just had a case where we recently did this. We'll do that if there's a finding that we can't accurately see, if they're not cooperating and we're worried about them bleeding, or potentially to get some evidence collection. We'll put them in these different positions: frog leg, knee chest, prone knee chest, and supine knee chest, and then supine lithotomy. So you'll probably see these in our notes. When you look at, when you read these notes, it should tell you what position they were in. So this is the supine frog leg position, and then how they did the exam. So usually we'll do labial separation. So we separate the labia and then we do traction, pull it towards us. And that's generally all we need to do. And we can see all of the more internal structures. So we can see the hymen. Sometimes it doesn't come into view all that well when they're on their back or supine. So we have them flip over and let gravity help us. And then we'll just kind of lift the buttocks up so that we can see those internal structures. In adolescence, sometimes we'll use a speculum, but that's pretty rare. But we'll usually use this lithotomy position where we have their feet up in the stirrups. Here's just some anatomy. What we're really interested in is we'll look at all of the anatomy of the vulva here. But then when we separate the labia minora, the small lips, then we can see the more internal structures. So we look to see, in particular, this ring of tissue here, which is called the hymen. And all girls are born with a hymen. And when we look at it, we will explain where we have findings, like a clock face. So you'll sometimes see that in our notes, that like at 3 o'clock or 4 o'clock, that's describing the position on the hymen where we've had the finding. And hymens come in all different shapes and sizes. It's just like your nose. The most common are annular, like a ring, and then crescentic, and then fimbriated. And there's lots and lots of variations. I'm going to show you what these look like. This is annular, looking like a ring. So you have hymen tissue that goes all the way around, very normal. And this is a prepubertal girl. Sometimes it doesn't quite go all the way around. This other opening up here is where the urine comes out, the urethra. The vagina actually starts beyond the hymen. And this is normal to see all this kind of like lacy vascularity on there, and see how it almost becomes a full ring. Sometimes it's just like a crescent moon. So it's just at the bottom where it doesn't come all the way and connect all the way at the top here. And here you can see inside to these ridges of the vaginal floor. Sometimes it's very redundant, so it's almost like a sleeve or like a tulip-shaped hymen. Sometimes there's a lot more hymen there, and this is all very normal. When girls go through puberty, they don't just have changes to what we see on the outside, so like the breast development, the pubic hair development. We also see changes to the hymen. So when they're first born, it has all this estrogen effect. Then when they're older and prepubertal, it goes away and it becomes very smooth, very, very sensitive. But then when they go through puberty, then again, it becomes very fluffy, kind of redundant. And this is all from the estrogen. So it looks more like a hair scrunchie. And so this allows it to become more compliant. It can stretch and not necessarily cause any kind of trauma. So we know that there are lots of myths out there that this doesn't happen in certain neighborhoods, that the molesters molest indiscriminately, that they would immediately tell their parents, that they would immediately show physical evidence of abuse. There's great studies that look at hymens and whether or not you see findings. It's very rare. So look at this one. Abnormal findings in only 14% of cases referred for sexual abuse evaluation. Here's only 4%. I think that the best one to look at is this one where they looked at, for adolescents at least, 36 adolescent pregnant females. And when you looked at all of them, most of them were normal. Only 11% were suggestive, and only 7% showed that they were definitive for penetrating trauma. Yet we know that it had to have happened because they're pregnant, right? And it was, occurred anywhere from 3 months. That was the average time from the last sexual contact until the exam, and about 1 month for the definitive group. And this is just a picture of, this is the hymen right here with a gloved Q-tip behind it. And you see the edge of this hymen. Trust me, this is completely normal. Yet she was 4 weeks pregnant. So the conclusions are that despite definitive evidence of sexual contact, only 2 of those 36 had findings that were diagnostic of penetrating trauma. So we know that you don't necessarily have to have trauma that's visible. And we also know that there's other studies, which I can share with you later, but that where they saw acute injuries to the hymen and then followed those girls up, and they completely healed up without any kind of definitive trauma. This is why the exams are usually normal. And even our counsel says, that this is often made just on the child's history. That's why the forensic interview is so important. So I think we're right at time. This is my summary. Know the training of your experts. Correlate those injuries with the history of the trauma or lack of history. Remember those high specificity fractures. Understand there are limitations to what we can say medically. No group is immune from child abuse. Remember the 10-4 faces P, and that in sexual abuse, it's normal to be normal. This is my email address, and I'll stop sharing this and see if we have any questions that popped up.
I don't see any questions. I know Carly has posted both the post-course handout and the post-course survey. If you have questions, you should be able to take yourself off mute, or you could put them in the chat box. We will send a recording out, or a link to the recording, after the series concludes. So probably the first week in November, we will just send the links to everybody who was registered and participated, so you can listen to them again. I apologize for the technical difficulties people have logging on. We think the wrong link was sent, so we're going to go check and make sure next week's link is correct. But I apologize for that. We will make the recording available, and Steve is willing to share his slides, so I will put them in a PDF, and we will get those for you as well. Carly, I will turn it over to you.
Thank you so much. That was so helpful. It really paints a picture of what we do on the medical side when we are looking at these cases before it gets to you guys in court. Thank you so much for attending. And also, just to add on to some of the housekeeping, the CLE credits, we're going to be submitting them all at the end of the course series. So you should see that on your Georgia bar at the end. Thank you so much. If there's any other questions, I'm not sure, but I don't think I see any. And we look forward.
Yeah, I'll stay on if you guys have any. Feel free to unmute.
Yeah, absolutely. I'll stay on.
You guys all have busy schedules. So sorry, we started a couple minutes late, so that's why I went over a minute. But
No, you did great. It was so helpful. You know, it's even good
I don't
because
see anything popping up. Somebody said thank you for the presentation. It's very much appreciated.
yeah.
And if in your jurisdictions, if you want, me or someone else from my team to come and do, spend some more time on one medical topic in particular, we'd be happy to do that. Just let us know. We want to make sure that folks understand, like what we can and can't say, and the limitations, and then what those really diagnostic injuries are. I didn't get into like with the sexual abuse, like the other things that are diagnostic of sexual abuse, like the types of infections and all of that. But we could definitely do that, depending on what the needs are in your, in your particular jurisdiction. Be happy to do that, and we could do it as a WebEx as well. Oh yeah, sure.
Yeah, all you would need to do is reach out to Dr. Messner. He can get that done.
Yeah, that'd be great.
Well, thanks everybody.
Right. Thank you for joining us, and we hope to see some of you again, or all of you again next week. Have a great rest of your day.
Thanks everyone. Stay warm.
Bye.